All right. Well, good evening, everybody. Thank you, Helen. Um, Glad to have everybody with us this evening, and we'll go ahead and talk through everything. As Helen said, my name is Michael Robish. I'm one of the cardiac surgeons here at Johns Hopkins,
And I'm Ronnie Hess. I'm one of the interventional cardiologists here at Hopkins as well.
and together we work on the structural heart team doing valve procedures, and so we're going to walk you through sort of some of the things that we think about and some of the cases that we see, and how we approach these problems.
Okay, so I'll have the pleasure of presenting the first case, and this is actually kind of modeled after an actual patient here for the past couple of months. So the patient's a 71-year-old man who presents with shortness of breath. And actually, this guy noticed this mowing his lawn over the summer. He actually had an episode where he passed out on the lawnmower. He thought it was just dehydration out in the hot sun, and he didn't think too much of it. But he noticed over the next several weeks he was getting more and more shorter breath, doing less and less activity. And then he eventually came to one of our affiliate hospitals and had an evaluation that determined that he had severe aortic stenosis, which is narrowing of the main kind of check valve coming out of the heart from the main pumping chamber to the water main vessel that feeds the blood to the rest of the body, known as the aorta, hence the name aortic valve. And so we were asked to evaluate the patient for treatment. Fortunately, there are no medications that are really effective in slowing this process down or reversing it. So really, when you think about treating aortic valve stenosis, you've got to replace the valve. I like to tell patients it's a mechanical problem and it warrants a mechanical solution. And there are two effective ways to do this. One is the surgical aortic valve replacement approach, and we'll detail this in a little bit, versus transcatheter aortic valve replacement. And they're both viable options for many patients. Surgical aortic valve replacement's been around longer, and we have more information about the durability of the devices that we use to replace the valve. But it is open heart surgery. It requires division of the breastbone, use of a heart-lung machine, full general anesthesia, and as a result, it's more invasive and requires a longer recovery. Whereas transcatheter valve replacement is attractive because it's less invasive, doesn't require full anesthesia, generally in most cases doesn't require heart-lung machine, and therefore is a shorter recovery. And that was our approach that we used for patients, generally when they're older and sicker, where surgery might be higher risk in particular. Although based on current data, we can really offer this to almost an adult of almost any age, but there are certainly factors that we weigh in doing that. And that's one of the reasons that we take this approach of evaluating every patient with an interventional cardiologist who has expertise in valvular heart disease and these catheter-based valve procedures, as well as a cardiac surgeon, to make sure that we are tailoring the right treatment for the right patient. And so in this case, usually in a patient who is under the age of 75, but generally over the age of 65, you could really go either way, all things considered, other things being equal. They don't have other heart problems that would benefit from surgery, like severe coronary artery disease or an enlarged aorta known as an aneurysm, or severe disease of another heart valve. And as we'll see, this gentleman had really isolated his aortic valve stenosis. He didn't have any other real heart problems. His heart muscle had weakened a bit, but we determined that was all related to his aortic valve stenosis. He had no blockages of the arteries that feed his heart muscle. And so we went through the whole standard workup, and he was favoring the less invasive transcatheter approach initially. And I remember going to review the results of his assessment. And one of the key assessments we perform is a specialized CT scan to look at the structure of the valve, its size, to look at the space around it in the aorta to make sure there's enough room to put the new valve in, and to also look at the arteries leading down from the heart to the extremities, to the arms and the legs, so see if we have a clear route to deliver the new valve, because a catheter-based valve requires a tube or catheter about as big around as your typical ballpoint pen. You got to make sure you have a vessel that's big enough and not too curvy. This figure here just shows us this the fundamental problem of aortic valve stenosis. So at the top panel, you see the valve looking in cross section when it's open and closed, and that's what a normal valve looks like. Those moving parts fit together like a trap door. We call them leaflets, and when we're born, they're tissue paper thin and very pliable. And then when you look at the bottom panel, that's what happens when you develop valve stenosis. And the most common form of this problem is that you develop thickening of these moving parts with plaque deposition and deposits of calcium like limestone, very akin to sort of what is often known as hardening of the arteries. And that's exactly what this gentleman had. So if we go to the next slide, and this is really the most common heart valve problem that we treat. This shows a three-dimensional reconstruction of this patient's aortic valve. And what you can just key in on here is the white stuff in the middle. That white stuff are the calcium deposits in this gentleman's valve. In this case, this person had an abnormality of the valve that he was born with, where instead of having two little moving parts or flap, or having three, he has two little moving parts or flap. So we call this bicuspid aortic valve stenosis. It affects about 1 in 100 people in the general population. It is the most common form of inherited heart disease, so it runs in families. And you can see there's a huge amount of this white stuff on this patient's valve. And when we quantified this, this was by at least an order of 2 or 3-fold the highest degree of calcium that I had ever seen on an aortic valve. And this really gave me a lot of pause, because when we think about putting a transcatheter valve in, and we'll show you this in an animation later, we have to open up this big metal scaffold or stent where the existing valve is. We don't remove the moving parts as would be done with surgery. So we have to be able to push them open. And I had very serious concerns that we wouldn't be able to push this valve open sufficiently to allow the new valve to fully open up. And so I walked into this patient's room and explained this and said, you know, I know you're favoring the transcatheter approach, but I think this is a situation where we may need the services of Dr. Rodich to perform surgery so that we can remove this calcified valve and then implant a new valve. And so, Dr. Rodich, why don't you take it from there and tell us how you thought about this?
Yeah, absolutely. So I had met him before the CT scan was done, and we had a similar conversation that you had had, that he was favoring the TAVR procedure, and I thought that was quite reasonable, and made a lot of sense, and I thought that that would be a good way to go. We then got to CT scan, as you said, and now we start to think about what would be the right thing. Fortunately for this patient, he really was a low-risk surgical candidate, so he could be easily considered for both. Some patients can't. Some patients really can only be considered maybe for one or the other, but in his case, I think both ways would have been reasonable. But ultimately, we want to get the best and most durable result we can get for him. He's 71. We'd like for him to live a long and healthy life, and we want to give him a valve that we think is going to last as long as possible. So after we had the CT scan and we talked about it, about this heavy calcium burden, I went back and met with him again and talked a lot more in depth about what the surgery, what the operation would look like, what the recovery would look like, why we were leaning, one way, and certainly at the end of the day, we don't tell him what to do, but we give our opinion, what we think is the best thing. And so I went through and talked about how for him, his risk of dying from an open heart operation would be less than 1%. Risk of a stroke would be 1 to 2%, and went through what I expected his recovery to be, and it is longer than with the TAVR. There's no doubt about it. In the hospital for 4 to 6 days after surgery, and then it takes most folks a couple, 2-3 months to sort of get all the way back to normal again. So it does take some time to recover, but in this case, we felt that this was going to give the best result, the most durable result, and so he spent some time thinking about it and going through it, and then we'll circle back in a little bit on sort of how this turned out. But that was sort of the conversation that we had.
Yep. Yeah. All right, Michael. So we thought we'd just talk about what you just witnessed here. What we recapitulated for the group tonight is our multidisciplinary quote unquote heart team concept. And this has been something that is not just unique to our institution here, but has been really popularized within our field nationally, internationally. We like to think we do it very well here, and I think we do. And this is the idea of multiple disciplines coming together to assess patients with significant heart valve disease, or really any major cardiovascular problem that might warrant some type of procedure, or there might be different types of procedures that could be options. And so, initially this was interventional cardiology or cath lab and cardiac surgery, but really it also involves our echo imaging specialists, our anesthesiology specialists, our EP or electrophysiology, heart rhythm specialists at times need to be involved. And one of the unique things when it comes particularly to valve disease and some of the new technology and transcatheter devices is that our biomedical and bioengineering kind of industry device companies have really played a pivotal role in helping to move this field forward in terms of their innovations and engaging with us to study and implement these devices in a rational and logical way under the auspices usually of the Food and Drug Administration and Centers for Medicare and Medicaid Services. But this is a model that we really try to follow through in our day-to-day practice, and it has several advantages for our patients. So first of all, it allows us to ascertain all potential treatment options. We determine the best treatment option for each individual patient. And as you can see here, there were unique characteristics of this patient that really were pivotal in directing what was the best option that we felt we should be recommending. It allows us to plan procedural approaches and detail contingencies. So we want to obviously plan for things to go well, but we want to be ready to know what to do and what not to do if things don't go well, what we can and cannot do. And then one of the things we haven't mentioned is that, particularly for the catheter-based procedures, we generally perform these procedures together and are actively engaged not only in the technical performance of the procedure, but actually when there are pivot points during the procedure, decision-making about whether to do one thing or the other. And sometimes there's not a black and white, right or wrong. It's a bit more of the art versus the science of medicine. It's nice to have at least two people there from kind of different perspectives to put our heads together and come up with a way forward. And then also in terms of managing the patient afterwards, I think it really helps to have both of our perspectives to think about the different issues that can arise and how to address them.
Mm-hmm. I have to say that's, as you said, it's not necessarily unique to Johns Hopkins, the multidisciplinary team, but I agree with you. I think we do it really well. We've got a lot of great experts, wonderful people with a lot of experience. And for me, it's one of the most fun things to put everybody's head together and come up with the best thing for each person. So now in this slide, we're going to the different types of valves we can use to replace. So when the aortic valve wears out, what can we put in there? And this is a picture of a mechanical valve. And so oftentimes for patients who are especially younger, we consider putting in mechanical valves. They last a really long time. They're very durable. Have to take a blood thinner with them. But for young patients, this can often be a very good and durable way to fix aortic valve problems. A lot of the valves we put in are tissue valves. They're made out of either cow or pig and can be used to replace valves. Here at Johns Hopkins, we use some of the newer technology. This is a different kind of valve. This is what we call sutureless or rapid deployment aortic valve. So with the mechanical valve or other types of tissue valves, we hand sew it in. Each part of the valve is sewn in and held in place, and it works very well. And about 10, 11 years ago, this valve came onto the market. And so this Percival valve can be used, and for patients who are maybe a bit older, a bit sicker, who will benefit from a very shortened operation, this valve is very advantageous. It can be put in, and we'll see a video of this in a few minutes, but it can be put in quite quickly. And so one of the situations where we like to use it is in patients who need multiple things during an operation. So sometimes it's not just the aortic valve that's a problem, but we have to replace the aortic valve, do bypasses, maybe 3, 4, 5 coronary artery bypasses, maybe a maze procedure for atrial fibrillation or repair and replace another valve. And so there's a lot of work we need to get done, and we want to get it done in a very efficient manner. And so this valve has been pretty instrumental in that. And here's a little video that kind of shows how this valve works, so we can talk through some of the specifics of that. And so, as we showed before, the left ventricle here pumps out the blood. It goes through the aortic valve. This is a nice normal aortic valve, thin leaflets, opens widely and lets the blood out. Here you can see the valve when it gets heavily calcified. It doesn't open so well, and maybe it leaks as well. So during surgery, we're able to go in and stop the heart. You see we stop the heart from beating, and we can do this safely. And then we open the aorta, we go in, we clean out that old valve, just cut that old valve out, get it all out of there, clean it all up, get rid of that calcium. And then this leaves a nice orifice where we can put a new valve in. And so there's this technique that we use for all different surgical valves. We sort of custom fit it to make sure that it's going to be just the right size. So we bring in these sizers that allow us to see exactly what size of valve we want to put in. And that way we make sure we're putting in the best valve that we can for each individual patient. So now this valve, and as we watch the TAVR valves, it's a very similar concept where this valve gets collapsed and put onto a holder. We put guiding sutures into the we call the annulus, where the old valve used to be, and we bring this valve down in, and we can deploy it. And this generally cuts down about in half the amount of time it takes to put the valve in. On average, it takes about 70 minutes to sew in a valve, and this one on average takes about 30-35 minutes. And you can see once it's deployed, we sort of do a little balloon dilation just to smooth it out, iron it out, make sure it's seated well. And once that's done, we cut those guiding sutures, and the valve works. It provides a very wide opening. We make sure that the size is correct. It provides a very wide opening. And in patients who we think are going to need another valve down the road, this provides a really nice platform for what we call valve and valve TAVR. So later on down the road, if these valves, they tend to wear out over time, the tissue valves do. And when they wear out, this provides a nice platform for potentially going back in through the groin and putting in a TAVR valve inside of it. And so those are the kind of things that we're thinking about. And now we'll talk about the more minimally invasive TAVR procedure.
One other, I think, advantage of the sutureless trapersal valve is that one of the things that people maybe don't realize is that when you're stopping the heart and you're doing all this, the patient is on the heart-lung machine. And while that's a miraculous device that really has enabled the whole field of heart surgery to develop, you sometimes don't want to keep somebody on very long.
That's
and in
right.
fact, one of the things that you guys pay very close attention to is trying to minimize the amount of time that the heart is on that machine, because there can be some injury to the heart muscle the longer it takes. So when Dr. Robish has to do multiple valves and bypasses all at once, really time is of the essence. So catheter-based valve replacement, or transcatheter valve replacement, TAVR for short. You may also see this referred to as transcatheter aortic valve implantation, or TAVI, which is probably a technically more accurate term, but TAVR is preferred in the United States. It's catheter-based, minimally invasive approach. So there's the open heart approach as Dr. Robish has described to us. Here is the catheter-based approach going through the femoral artery in the groin or the top of the leg. We don't open the chest. We don't divide the breastbone. We don't use cardiopulmonary bypass or the heart-lung machine. And generally, we can do this with sedation, so we don't have to put the patient to sleep or on a breathing machine. So it's less invasive, so comparatively, it's a shorter and easier recovery and lower risk of procedural complications, typically, especially for an older patient who has other health problems. A patient like the 71-year-old we discussed, the risk of serious complications, things that lead to death or things like heart attack and stroke, are going to actually be similar between open heart surgery and TAVR. So here's an animation that shows a TAVR procedure here. So that's the valve beating in the heart, as we've seen in previous animations. And I'm just, for the sake of time, going to forward this a little bit to show you. Here's the tube going up the leg, coming around under X-ray guidance. You see the heart is beating in this case, and we're visualizing this through X-ray. And we basically withdraw this plastic sleeve to release this stent or scaffold that now houses a valve rendered from the lining of a pig's heart that is made to look and function like the valve we're born with. And rather than cutting out the old valve as Dr. Robish would do during an open procedure. The old valve is pushed out of the way. You can see here splayed open, and we just have to make sure, based on assessment before the procedure, that there's enough room to do this in terms of space for the blood to flow to the arteries that feed the heart muscle, and that we have plenty of room to come up through the arteries in the leg, or say the neck, and come down and deliver this device.
Excellent. So the next, if you don't want to see surgery pictures, the next one is this is an actual picture of a valve. So this is when we do surgery. So we go back to our patient, our 71-year-old man, and this is his valve here. And we can see, as we saw on the CT scan, that what we call the bicuspid, these two leaflets here are fused right down here. A ton of calcium here, here. And this third leaflet also, or the second leaflet, very calcified, very thickened, and you can imagine that this valve doesn't work very well. And so I cut it out, and then here is that Percival valve as it's placed inside. This is how it looks before we close up the aorta and restart the heart up again. And this valve worked wonderfully. The patient recovered, did excellent, and continues to do well. And so that was a nice case, and it was a lot of good work, I think, from the team to figure out the right thing here. We'll go into the second case now. This is a woman that I was asked to see, 85 years old. She has high blood pressure and has a mitral valve that isn't working very well. So now a different valve in the heart. In this picture here, you can, on the left, you can see the aortic valve here that we were talking about. Now we're talking about the mitral valve. So as the blood comes back from the lungs, the oxygenated blood comes back from the lungs, it goes into the left atrium, goes through the mitral valve into the left ventricle. The left ventricle is the main squeezing chamber, so it squeezes and pushes that blood out through the aortic valve to the rest of the body. So in this patient, we're having what we call prolapse. So one of the leaflets is kind of prolapsing, or is riding up higher than the other leaflet. It's not normal. And sometimes these cords down here that are supporting the valve can break. And here we can see that when they break, we get a flail leaflet. And now this mitral valve is leaking severely. And for this woman, it was causing her shortness of breath while she was out gardening, doing her work in the yard. She becomes short of breath, and that's an uncomfortable feeling. And undergoes an evaluation, finds out that the valve has a flail leaflet, it's leaking. And from a surgeon's perspective, these are wonderful operations to fix valves. One of my favorite things to do is repair these valves, and it can be a lot of fun, and we can fix them. And one of the ways that we do that is, through open heart surgery, which is the traditional way that it's been done for a very long time. And in this case, one of the things we can do is cut out that bad portion, this prolapse portion with these broken cords, just cut that out, and then bring those two edges back together. And what we do is we put a little ring on there to support the whole valve. It usually gets dilated out, so we bring it back down to its normal size. And this can be done in this situation. Oftentimes we can repair these about 95% of the time, so we don't have to replace the valve, and it can usually be done very safely. In this case, wonderful woman, 85 years old, though, felt like open heart surgery would be an awful lot for somebody who's in their mid-80s. A lot of work. The recovery would be, in this case, we're talking about a recovery that's probably closer to 5 or 6 months for open heart surgery. So, it's something that can be considered. But really, if there's another option that we could go with for somebody like this that didn't have a recovery time that was long, then we want to look into that. And so that's where we look at some of the other options that we have. One of the techniques that we've worked on that is not open heart surgery, but can, in a lot of ways, repair a valve in a similar fashion. This is a technique that's experimental, but we've been able to do it in some patients where basically we can make a small incision just on the side of the chest instead of going down the middle of the breastbone, and use this device with guidance from an echocardiogram to put new cords on. And so basically replacing those broken cords on the valve, and that prolapse segment that's riding up high, we can bring it down so the valve comes together at the same level each time. And so this is one more minimally invasive way to approach a valve, but there's even more minimally invasive ways to approach a valve.
Yeah, we should say that that kind of beating heart technique to repair the valve through a small incision is actually being pioneered by one of our partners here, Dr. James Gammy. So the other approach is to avoid making any incisions in general and going up through a catheter or a plastic tube, this time in a vein in the leg. And we can come up through that with ultrasound and x-ray guidance and come into the heart. And then what we attempt to do is we can't achieve the type of repair that Dr. Robish or Dr. Gammy can do when they do open heart surgery in terms of trimming the moving parts or leaflets and putting new cords in. But what we try to do is essentially emulate or recapitulate a surgical technique where, let's say, the surgeon is trying to do the procedure very quickly. It's an older, sicker patient. Maybe the heart function is not very good. They don't want to be on the heart-lung machine very long. So what they sometimes would do is just put a little stitch between the two edges of the valve where the leakage is occurring and kind of pin them together. And that would not eliminate the leakage, but often make it go from severe to less than severe, where somebody will feel better. So it's not a perfect repair by a design, but if it's adequate in terms of improving quality of life, especially for somebody, let's say in their 80s or 90s, or maybe even a younger patient who has other health problems that may limit their ability to undergo or recover from surgery, then this is a good option. There are now 2 FDA-approved devices for this technique, which is sometimes called transcatheter edge-to-edge repair. And here is a device called the Pascal device that basically has these 2 arms, and we try to grab the 2 edges of the leaflet in each arm and then bring them together. And this particular device has a little spacer, so if the valve is kind of very floppy, it's kind of nice to have that spacer in there to help bring it together. This just was approved just in the past year. The device that got first approval was the MitraClip, and so you often refer to the procedure generically as MitraClip, although really it's referring to one particular device and vendor. And you can see in this diagram here, the top left is the showing you what the Alfieri stitch surgical procedure would look like. And basically what this procedure is with putting these clips here is trying to recapitulate that, usually with 1 or 2 of these devices that can be delivered, again, through a needle puncture. Now, in this case, we still have to put somebody to sleep on the breathing machine because we use an endoscopic ultrasound or TEE probe to guide the procedure while we're actually working on the heart as it's beating and we're trying to position these clips. But for a lot of older patients, or patients who have other health problems that limit, I think, the ability to recover from surgery, this is a good second option right now. Previous studies have shown that you don't get as good of a repair compared to surgery, although we now have a randomized control trial ongoing where we are actually taking patients who have this specific type of mitral valve disease, as Dr. Robish showed you, mitral valve prolapse, or what we call primary mitral valve regurgitation, who are at least 65 years of age, who only need their mitral valve fixed. They don't have any other heart problem. They don't have blockages. They don't have aortic valve disease. It's isolated mitral valve disease. And we then, if they look like their valve is amenable to either a catheter-based edge-to-edge repair or a surgical repair with high probability of success, then if the patient is interested in the study and consent to it, we then perform a randomization that's a computerized coin toss between surgery and catheter-based repair. And we're going to be looking at those patients for a minimum of 5 years to see how they do, to kind of reassess that with modern catheter-based techniques. These devices are now on their 3rd and 4th iterations. And we have a wider variety of devices in terms of sizes to use. Can we get an equivalent result compared to surgery? And if that is the case, then this can be potentially considered as an equal to surgery, the way TAVR is compared to surgical aortic valve replacement with the aortic valve. But right now, as it stands here on January 24th, 2024, our first preference is to do surgical repair because it's generally a higher quality repair, and use this percutaneous or catheter-based approach as a second line option if we don't think it's a great idea for the patient to have surgery. So we'll just show you a little video of how this works. So again, we go through a needle puncture, this time in the vein in the leg, and we're going to go up to the right side of the heart, but your mitral valve is over on the left side. So we use a specialized apparatus under real-time ultrasound and x-ray guidance to make a controlled and precise puncture through the little thin-walled barrier between the right and left heart. And then that allows us to bring this device all the way in. As you'll see, we put a little tube or catheter in over this guide wire. And that will allow us a portal to then bring the clip device in and position it right over the mitral valve. And then we orient it to the location where the leakage is emanating from. Sometimes it's the middle of the valve, sometimes it's the right side or the left side. And we try to go right where the problem exactly is. So here we're orienting it, and we're testing the function of these little arms to be able to grab the valve properly. And then we're going to come underneath the moving parts of the valve. And as you're going to see, we'll come up slowly under real-time ultrasound guidance and some X-ray guidance. Try to get both edges of the valve into this. We don't have as much as we'd like. We can adjust its position and then bring the two edges closer together and then assess how much, if at all, we've reduced the leakage. We create this double opening instead of one big opening of the valve. So one of the things we want to make sure that is we don't create narrowing in the process of doing this. And then if we're happy with the device, we release it. We see if we need another one. And this cartoon is a little unrealistic. We're never left with zero leak. So here it's showing you there's a bunch of leak before on the right-hand side, and after the clip is deployed, it's showing no leak. That's not reality. There's always going to be, at least I would say, a trace to mild degree of residual leakage. But even if you can get it down to a moderate degree, for some patients, that's going to be enough. And that's the end of our slides, and I think we're right about on time.
Great. All right. Let's see. All right.
So that's a great question. So I'll read the question for the audience. So can the regurgitation heart valves return to normal without surgery if high blood pressure is brought under control? And so, yes, so leakage of heart valves can be a very dynamic process, and it can be dependent on a number of factors, including high blood pressure. And so in certain instances, we can reduce regurgitation by controlling blood pressure and controlling volume status and other factors. In the case that Dr. Robish presented, the second case where we had the mitral valve prolapse and flail, for example, that's not something that's going to be corrected entirely with blood pressure control, for example. Generally, that's a mechanical issue that needs to be corrected. And so in those cases, but sometimes the valve leaks because the housing is just being stretched. The moving parts of the valve are actually just fine. And so in those situations, yes, we want to make sure we have optimized all of the factors, make sure the patient's on a good medication regimen, and then reassess the leakage before we decide whether an intervention is necessary. All right, so here goes some more questions. You want to take the next?
Sure. If I had an aortic valve repair some years ago and still have some leakage, could I be considered a candidate for TAVR?
So it depends on what you've had done. What is more likely is if you had a valve replacement previously, let's say through a surgical approach, then oftentimes for the second procedure, if that valve is now worn out or is leaking, for example, has become narrowed, then we often look to doing a TAVR within that pre-existing surgical valve as the first line treatment. And only when there are technical issues with that we identify based on CT scan or something like that, do we generally then recommend redo surgery for most patients.
Yeah, I think if the valve is still leaking or is leaking again, and there's no calcium or anything like that, oftentimes we do talk more about doing surgery again. But this is exactly why we have the multidisciplinary heart team, is to really look at the details and understand exactly what's going on and figure out what the best thing would be. All right, question number 2. What treatment do you recommend for anomalous origin of the right coronary artery?
Throwing us a curveball off
that's an interesting
valve.
one.
So, from a medical standpoint, usually anomalous origin of the right coronary off the left coronary cusp or off the left main typically is considered reasonably benign. And so as long as it's not causing somebody significant symptoms, we generally don't recommend intervention for it other than medications. Now, there can be rare instances where because of the way the right coronary is coming off, if it's coming through the wall of the aorta and its flow is compromised through it, which generally would result in symptoms, then treatment would be recommended. And in general, surgical treatment is preferred. And that's more commonly recommended when you have an anomalous left coronary artery off the right, because that often is associated with a higher risk of sudden death. And so that generally is treated, typically with well, Dr. Robich, I'll let you answer what the surgical techniques are.
There's a number of different surgical techniques to manage this. Probably one of the most common is what we call unroofing, which is basically just opening up the part of the aorta where the vessel is running through it, just to open it up and make the orifice larger so that blood can flow through more easily. There are definitely some other techniques, but by far and away, that's usually the most common, and that is open heart surgery, just as we talked about with other things, to get after that and fix that. But we can do it safely, and certainly do a handful of those every year here. So we see it relatively commonly. All right. How can patients prevent calcium deposits, and what is the cause of the buildup? That's a good question.
Yeah, so the cause of the buildup is very similar to the buildup that occurs in the arteries throughout the body, whether it be in your heart, your brain, in the artery going to your legs or to your abdominal organs, for example. And generally, by and large, good lifestyle habits, eating a prudent diet, rich in vegetables, low saturated fat, low simple carbohydrates. If we were to recommend a specific type of diet, the Mediterranean diet seems to be the one with the most data behind it in terms of reducing the likelihood of developing atherosclerosis. Now, that being said, despite doing all those things, some people, if they live long enough, are going to develop calcium deposits on the aortic valve. And really, we haven't found, other than good diet, regular exercise, we haven't found a good way to prevent that calcium deposits otherwise. We have done some studies looking at statin medications, for example, and perhaps if they're used very early on, they may help. But certainly once you have some deposits on the valve already, particularly if there's any valve narrowing, they don't necessarily make a difference specifically when it comes to the valve, but may be important to prevent plaque buildup in other locations.
I think that's good. And if you smoke, you shouldn't smoke.
Yeah, it's
Stop
another
smoking,
important factor.
For
Very much
calcium all through the body. It's a good question. All right. What is the best imaging to diagnose valve issues disease? MRI versus echo? Good question.
Yeah, in general, the first line evaluation for people with any kind of structural heart disease, and namely valvular heart disease, is echocardiography. In general, what we call transthoracic echocardiography, or just a surface echo. So it's a very simple test, kind of like when a pregnant woman gets an ultrasound to look at the fetus. It's very similarly performed to that. Non-invasive, can be done in the outpatient setting in the office. And that's really the best way to screen for things. And then if that raises any concerns, for certain conditions, it can be definitive. In other conditions, you may need additional types of ultrasound, such as a transesophageal ultrasound, which is an endoscopic ultrasound, needs to be done under some sedation. That is often preferred to better evaluate mitral valve disease. Mm-hmm. Generally, for aortic valve disease, transthoracic or surface echo is sufficient. And if there's any question about, well, how severe is the valve? Are we underestimating it by the echo? Then we turn to catheterization-based techniques often. MRI can be helpful with regurgitant valves to quantify the regurgitation if there's any question, to look at the size of the heart muscle, or if the heart muscle is weak, to see if if the heart muscle potentially is not dead, but maybe what we call hibernating and maybe recovered. But we use that more selectively, generally in patients with valvular heart disease. It is generally better to evaluate people who have concern for different types of heart muscle disease. And then, of course, we use catheterization, and then CT scan is very central when we're planning, say, a TAVR procedure, often for surgical procedures, so we often use that.
Excellent, excellent. All right, question. Does age play a factor in what type of valve, tissue versus mechanical, you recommend to your patients? Do younger patients typically go with a mechanical valve, and how long do they last? And the answer is yes. For younger patients, we generally do recommend a mechanical valve, especially in patients who are 50 or less. We really feel like the mechanical valve is more durable. And in general, they really will last, and oftentimes they can last forever. Now, the risk of having another heart operation if you have a mechanical valve is not zero. So if you're young and you have a mechanical valve replacement, you still have potentially a 10% chance of needing another heart operation at some point. And so, but with like everything we do, we try to take each patient into account. Sometimes, we have young patients who want a tissue valve because they don't want to be on blood thinners for certain reasons. They may have a job or a hobby that would be at high risk. If you race motorcycles or cave diving or something like that, you may not want to be on a blood thinner. The patient may say, look, I understand I'm going to get a tissue valve and that it's going to probably wear out in my lifetime, and most likely I'm going to need another procedure. And in patients who are very young, 40s, 50s, if we put in a tissue valve, a TAVR, valve TAVR, may not be the next procedure. We'd have to talk about that and figure out what the lifetime management of this valve disease is going to be. But it might be another open heart operation. Sometimes younger women who are planning to have children may say, I want a tissue valve now after I have my kids. I'll have open heart surgery and go back to and have a mechanical valve at that time. And so there's certainly a lot of discussion that goes into this. And I think we definitely don't want to tell anybody what to do. We want to help provide the best information we can to help make a good decision. All right. Here's a good one. Is the heart ever stopped during TAVR? How long is the recovery after TAVR? That's a great question.
Yeah. So the answer to the first part is not intentionally. So we don't have to stop the heart during TAVR. So your heart is beating. It doesn't require being on a heart-lung machine. In general, the only situation, and we did one this week, but that was probably the first time in a couple of years where we did it, was where somebody had a very, very weak heart muscle, and we were worried that during the positioning of the valve, we might just put a little bit too much stress on the heart than that weak heart could tolerate. And so we actually used a heart-lung machine put in through tubes in the leg just to support the body and support the heart through that process. But the heart was still beating throughout. And in general, we don't need that kind of support with a healthy heart muscle. The little bit of stress that we put on during the deployment of the new valve is well tolerated. What we do tend to do is make the heart actually beat more rapidly than it would normally be beating while you're asleep. And sometimes we make it beat fairly rapidly, consistent with somebody doing vigorous, say, aerobic exercise, so that the position of the heart is kind of more stable while we're visualizing it under X-ray, because we're often positioning these valves very precisely and slowly, opening the valve so that we get a nice, precise position, minimize the chance that we get, too deep or too high, and hopefully make it so that we get a perfect positioning for each patient. The recovery, 90% of our patients go home the second day. And the things that will keep patients in the hospital more than one day is if we want to keep them longer to monitor their heart rhythm and see if they have developed a need for a device called a permanent pacemaker. That occurs in about 7 to 10% of TAVR patients and about 2.5 to 3% of patients who have surgical aortic valve replacement. And it's related to the fact that the heart has an electrical circuit and some of the important electrical fibers of that circuit run in close proximity to the aortic valve. And so whenever we're kind of mucking with that valve, we can impact those fibers. But otherwise, it's a night in the hospital typically, and then we have people take it easy for a week with no strenuous activity, no weight training, no lifting more than 5 to 10 pounds for the first week. People can walk and climb steps and resume a lot of normal activity within that first week, but really exercise, swimming, things like that can't be done for the first week. And then after 1 week, you go back to normal unrestricted activity.
Excellent. All right, so in a patient with history of aortic aneurysm and dissection due to connective tissue disease, if a valve is needed, would that patient do better with a mechanical or a tissue valve?
That's a good question.
That is a good question. So there's a lot here, obviously. So in some patients who have a bicuspid aortic valve disease, they may have aneurysms and may be at risk for an aortic dissection, which is where the layers of the aorta sort of peel apart, kind of like wallpaper coming off the wall or an onion peeling. And that's often dealt with as a surgical emergency. So if you have a dissection of your ascending aorta, we oftentimes do emergency surgery to prevent death. And so these can be very tricky operations that we have to do. And at that time, we assess the valve to see if it needs to be repaired or replaced during surgery. Sometimes the valve looks good during the operation, so we don't have to replace it. But later on, it may become a problem. In these situations, usually we're talking, we go back to usually the age question. How old is the patient? And when discussing a mechanical or a tissue valve. And so those can definitely be good discussions to have. And in these cases, not only are we watching the valve, and is it leaking, is it functioning properly, but we watch the rest of the aorta as well. And does it need to be replaced? Oftentimes during emergency aortic dissection surgery, a portion of the aorta is replaced, but there may be residual aortic dissection that has to be dealt with down the line. And so these are things that we want to look at in a very collaborative way. And oftentimes we do that with our vascular surgery colleagues, as well as our cardiology colleagues. So we're bringing in even more minds and people to think about things. So these can be challenging cases. All right. Oh, this is great. Can anything be done to correct severe tricuspid valve regurgitation? This is a great question, and one that we really are dealing with a lot more these days.
Yeah, so there was a period of time where people kind of referred to the tricuspid valve as the forgotten valve, because there was kind of a dogma that tricuspid regurgitation was always due to left-sided valve disease, mitral regurgitation or aortic valve disease, and that if you just fix the left-sided valve, the tricuspid regurgitation would get better. And it turns out that generally is not true. And we recognize that there are a wider variety of causes of tricuspid regurgitation. As it stands right now, generally the best treatment for a lot of patients ideally would be surgery to repair the valve when possible, or replace it if a repair is not possible. Now, part of the problem that we tend to see is that because of that old dogma, a lot of patients don't get referred into our team, for example, until the severe tricuspid regurgitation has become very severe and has impacted the rest of the heart, or particularly the right side of the heart, and even sometimes other parts of the body. And in that situation, sometimes then surgery becomes too risky, or let's say the patient has had a previous open heart procedure and now they're in their 80s and they've already had open heart surgery. Dr. Rubish, as enthusiastic as he is about open heart surgery, doesn't get very enthusiastic about those cases. Mm-hmm. And the data support that those types of cases, taking somebody back to the operating room who've already had open heart surgery with severe tricuspid regurgitation, those outcomes are not great, and there is a higher risk of death with those procedures. So we try to get those patients in earlier for surgical treatment. But if surgical treatment is high risk, there are catheter-based approaches that we are currently actively investigating. Nothing is yet FDA approved. One device, which is basically another version of the Abbott MitraClip, which is simply re-engineered so that it can be delivered easily into the tricuspid position. Recently, they had a trial that was done that was presented almost a year ago now. And so their data has been at the Food and Drug Administration for some time. And we anticipate they're probably going to get approval for use sometime this year. And then we'll be implementing those devices. We've done it in a couple cases off-label. We are actually doing a parallel trial or kind of a sister trial using the Edwards Pascal device to do edge-to-edge repair of the tricuspid valve, again, under investigational auspices. We just did a procedure on Monday that went very well. We've done a number of them now. And we also anticipate probably in the next year or two that a catheter-based valve replacement platform will be approved. And we anticipate having that just as soon as it is approved and contracts can be worked out between the vendor and our hospital. So options for that are evolving and more to come.
Yeah, I think it's a great summary. Absolutely. On the surgical side, tricuspid valve is technically not the hardest thing we do, but definitely challenging if the liver is having problems, if the right ventricle is having problems. There's a lot of things to think about in those, for sure. All right. So here's a more specific type question. Patient had endocarditis, ended up with a hole in a native valve in the valve they were born with 7 years ago, and it was repaired by fixing that hole, and now there's moderate to severe leakage of the valve. Could I use a transcatheter valve to cover that hole? That's an interesting question.
Yeah, so the devil's always in the details. So in general terms, we would say that TAVR is not indicated to treat isolated leakage of a valve you're born with. If you had a valve replacement that's now leaking, that's easier to deal with because you have kind of a rigid structure that can support the TAVR device. But when it's a native valve, then the question becomes, well, is there something that can grip the frame of the TAVR device and allow it to have a stable seating? And so if the valve itself has a lot of calcium deposits and at least is somewhat thickened, even if it's not severely narrowed, then that's a potential option. But in general terms, if you were a reasonable candidate for redo surgery would be strongly favored as the most effective and safe treatment, frankly. And if for some reason another operation was not a good option, because of risk, because of age, because of other problems or technical issues, then we could consider performing a TAVR off-label. There are some devices that are being designed for, to perform TAVR, where the device itself is really designed to treat valve leakage as opposed to narrowing, or both. But those technologies are not yet approved for use in the United States.
Yeah, and I would completely agree with that. The devil really is in the details. We'd want to do some very close evaluation of the valve to understand why it's leaking, and see what the options are there for sure. But that's challenging, absolutely. All right, is TAVR performed in a hospital or ambulatory surgery center? That's a good question too. I like that.
Yeah. So at this point, it is still a hospital-based procedure and generally necessitates a one-night hospital stay. I've heard a couple of our peer institutions, particularly during the pandemic, starting to do same-day discharge in very carefully selected patients who are being done early in the morning. But really, it's best to monitor somebody overnight on a continuous heart monitor to look for any problems with the electrical activity. You wouldn't want to miss something like that. We wouldn't want somebody to have a problem like that at home after a successful procedure. So right now, it's still performed in the hospital and requires a one-night stay.
All right. Well, this is one that you have a lot of thoughts about, and I think a lot of people in the field are going to start talking about soon. And that is the MitraClip preferred over the Pascal due to how new the Pascal device is on the market?
Yeah, it's a great question. And I would say in general, the answer right now is no, because looking at kind of rigorous head-to-head comparison in the context of clinical trials, we have not seen any significant difference between the two devices. I will say that the MitraClip has evolved. In the first iteration, MitraClip was not as good as the devices we have now. They were more limited in their ability to treat certain types of pathology because of their size and limitations of size. And the Pascal doesn't quite have that. The Pascal has tried to address some of the technical pain points for the operator performing edge-to-edge repair with MitraClip. And I would say it has some potential technical advantages, but they haven't necessarily shown improvement in outcome, at least in the rigorous studies. But I think we're going to need more time to compare the devices to see, do any differences emerge over time. But right now, for patients with primary mitral valve regurgitation, similar to the case that Dr. Roba showed, the two are considered equivalent. I should add that right now, MitraClip has additional labeling to treat what we call severe secondary mitral regurgitation. That is regurgitation not due to a problem with the moving parts of the valve itself, but when the housing of the valve gets stretched because the heart muscle is weakened from some other problem, typically, let's say severe coronary artery disease with heart attacks, or somebody has had a condition called myocarditis, and the heart muscle is now weakened and enlarged or dilated. Generally, in those situations, we treat with medications to try to improve the heart function. But if despite all the medication treatments and all other indicated treatments, the heart muscle remains weak and the patient still has symptoms in the context of severe mitral valve regurgitation, severe secondary mitral valve regurgitation, then edge-to-edge repair has been shown to improve outcome, both in terms of improving symptoms, reducing the risk of getting hospitalized with heart failure, and even reducing the risk of dying over the next several years due to congestive heart failure. Right now, only MitraClip has labeling because they were able to complete their trials earlier. Edwards Life Sciences, who make the Pascal, is in the process of doing their trial in secondary mitral valve regurgitation, and we expect that will probably show similar results to the MitraClip.
Excellent. And then just one more quick one there. During aortic valve surgery, is it possible to have the valve repaired instead of replaced? And in some instances, the answer is yes. In a valve that leaks, a regurgitant valve, we can sometimes repair those valves and do a lot of assessment with certain types of echocardiogram to understand if the valve could be repaired or not. Certainly, we like to repair valves instead of replace them if we can. We have much more experience with repairing mitral valves than we do with aortic valves, but certainly could be considered. We'll wrap it up, I think, now. Thank you, everybody, for your time this evening. This was a lot of fun. Hope everybody got some information and enjoyed it. And we're certainly happy. There's a phone number at the bottom if you'd like to reach out with specific questions or other things that we can help you with. We're certainly happy to do that. And we thank you.
Yep, and thanks again for joining us, and we hope this was informative.
All right. Good night.